Welcome. This is our EQuIP webinar on survey readiness, and we are delighted to have Randy Benson join us today. So thank you all for attending. As usual, I want to start with a few announcements. Our next webinar will be July 22nd. We will have Jason Lemp from the Department of Health talk to us about mandatory reporting for critical access hospitals in Washington State. So far, that is the last webinar we have scheduled at this time. We will have more, but what I'd like to announce is that those hospitals that have enrolled in our EQuIP program, we will be having a conference call probably in August, where we'd like you to come and participate, and we want to talk about the structure of our collaborative improvement efforts that we're going to be working on with infection preventionists and what you're struggling with. We want to hear about that, where you'd like to go with the next education pieces. And then we also want to show you a new resource from APIC on the roadmap for the novice infection preventionist, because I think what we'd like to do is align the EQuIP program with that roadmap so that we're all working towards certification together on that. So we have a lot to talk about then. Be on the lookout for the invitations to that conference call, and hopefully we'll have some data we can present to you as some baseline at that point. So those are some calendar items. Also, we are still waiting for others, critical access hospitals, to join EQuIP to turn in their enrollment forms. If you need some forms, please contact me. I'm happy to get those to you. It's just some paperwork so that we make sure we have the contact information and that we have your conferred rights, so we can begin to benchmark data and help you with your infection control, making the business case and that sort of thing. So that's all I have for announcements. If you have questions, please feel free to use the chat. We will also have an extended question and answer period. We have booked 90 minutes for this webinar. Randy says he doesn't think he can talk that long, but I bet we can. But do know that we have extended time for questions, so feel free to stay on for that amount of time. Also, I know that Tyler has said if you use the chat to say all participants. Now, if you choose anything else, there's a chance that we on the panel won't be able to see that. So I just want to reiterate that one more time, because in the last few webinars we had a different selection, and then people thought that we were ignoring their question when in fact we couldn't see it. So just keep that in mind. And with that, I'm going to introduce Randy Benson, who will be talking to us today about survey readiness. Now, Randy is a consultant with the Washington Hospital Services Healthcare Quality Service, which is an external peer review and safety service used by 36 Washington State critical access hospitals. Randy brings over 30 years of healthcare administration experience with a passion for quality improvement, safety, and infection control. Randy provides a wealth of understanding of hospitals and, in particular, healthcare quality and safety improvement programs. Randy understands the Department of Health survey process, and he's an expert on the Joint Commission. In addition, he's a Six Sigma Green Belt and knowledgeable in lean process improvement. We are very grateful to have Randy with us today. And with this, I'm going to turn over our presentation to Randy.
Good afternoon, everyone. And Jamie, thank you very much for the introduction. Let's get started then. We'll talk about some survey readiness for infection practitioners, infection preventionists. The objectives for this presentation to include the ones that you see on your screen. We're going to talk about the standards that we have for infection prevention readiness for survey. We're going to identify the two major areas that you are responsible for in terms of both survey and competency for the Joint Commission, DNV, or for especially the Centers for Medicare and Medicaid Services. We'll talk about those citations which are the most common for the environment of care side of your job, and those questions or those citations that are most common for the clinical process piece of your job. We want to identify the different agencies that are responsible for survey readiness related to infection prevention. The Department of Health is or the foundational piece of survey readiness and competency for you as an infection preventionist. It is the Department of Health's responsibility to make sure that your facility is in compliance with the state's WACs and RCWs, and also in compliance with the Medicare rules and regulations. These are all requirements for licensure as your own facility. CMS, on the other hand, is responsible for validating the Department of Health's survey process, making sure that the Department of Health's licensure or survey readiness piece is in compliance with the CMS rules and regulations, and make sure that everything is in the right order in order for you to receive Medicare funding for patient care. So you have the foundation of the Department of Health. The Department of Health is responsible for doing both the WACs and the RCWs, and it's also responsible for making sure that you are in compliance with the CMS regulations. CMS, or the Department of Health surveyors, on a 5-year basis come in and do a validation survey of the Department of Health process to make sure that everything is in proper order and that you are in compliance with everything that needs to be done for Medicare funding. The other piece of that, and kind of to some degree the frosting on the cake, is if you are Joint Commission or DNV certified, you have a process in place then for best practice for all of the standards for patient care, including those for infection prevention. I do want to mention that at the end of this particular presentation, and when you receive a copy of the evaluation form, the SurveyMonkey evaluation form, you will also receive a document from me that is the references for the links that we're going to be talking about for survey readiness for you as an infection preventionist. Some of these are very large documents. I will warn you of that up front. The CMS Appendix W is about 125 to 150 pages, but it is important that you have that, so be prepared at some point in time if you're going to print them, and I would highly recommend that you do, that anticipate that they are large documents and they will take a little bit of time in order to get it all done. But those 5 documents are very valuable to you. They give you insights into the foundation for your preparation and competency as an infection preventionist. And they also give you the best practices that are identified by both the Joint Commission and DNV. All right. Let's talk first off about a little bit of the background. What you see in front of you now is the most common citations that have been received by hospitals during Department of Health survey. These all fall into the general perspective of the WACs and the RCWs for the hospitals, which is WAC 246, 320, 176. And what you see there for each of those numbers are the subcategories within this general realm of the Washington Administrative Code. So again, within 246, 320, 176, the number 1 citation received by hospitals during survey was that the policies and procedures, the policies of the Infection Control Department, were not up to date. They were not in the format they were supposed to be, and they had not been reviewed within the past year and had not been revised within the past 3 years. And as you can see, out of the 27 critical access hospitals that were reviewed during that period of time, 19 of them received citations for infection control issues related to policies and procedures. The second one, and I find this quite interesting, is that the second one is, again, related to patient care policies, but it specifically talks about dietary practices and talks about things which have a great amount of overlap between the clinical processes and the environment of care processes, specifically focusing on dietary practices, specifically focusing on what happens in the kitchen, how food is prepared, how food is handled, how food is stored, and how food is transported to the patients. Notice a fairly high level of citations for that one also. The third one deals with proper storage of drugs and medications and proper handling of those medications in order to prevent them from causing infections as opposed to preventing infections, as an example. Some of that is related specifically to not doing daily temperature checks on refrigerators and freezers, either in the laboratory, in pharmacy, even refrigerators or freezers in the nursing units. And we will come back to this one and talk about it a little bit more later on. So those are the most common citations within the clinical processes area. The last 3, if you see, are either environment of care or overlap between environment of care processes. One of them, the number 222, is safety of equipment used in patient care. What happens is that you get citations fairly easily when the surveyors find out that equipment is not being cleaned properly or cleaned often enough, or in some cases there is a gray area between who is actually responsible for cleaning that equipment in order to maintain sterile processes, or at least clean process for use in patient care. Notice the 271, the next one down. It is related to patient care policies. It is related to the patient care process, but it also has an overlap into environment of care. This says in this one that the policies of your facility are not written in accordance with state law. So if you go to the top of the page where you saw 278 that talks about infection control policies not being reviewed and revised in a timely fashion, 271 talks about the way those policies are written so that they are within compliance or within synchrony of what the state requires for written policies and procedures for infection prevention. It may be that the scope of the policies and procedures is not wide enough to accommodate all of the different services that your hospital provides, or those policies may be older than what you have, and you've added new services to the facility since the policies were written, and they have not been appropriately updated the way they should be. And then the last one is hopefully the least common of those, which are most often cited, and that is that the infection control process is not meeting the needs of the patient and or the family members, the guests, visitors, volunteers, the staff, and the physicians in the facility. So there are the 6 most common areas in which you see citations. It's not necessarily the only ones there are, and it's not necessarily one that occurs most often. There are other ones, interestingly, that most often are reviewed and looked for by the surveyors, but it's not necessarily ones that are most often cited by the surveyors. All right. Let's talk a little bit about the core of what you need to know and what you need to do in order to be a competent infection preventionist in your facility. Let me back up a little bit and explain it to you this way. When the surveyors come in to do a survey for the Department of Health or Joint Commission or DNV, they are looking at 2 pieces of your function. They are looking first at your core competencies. Are you competent to be the infection preventionist in your facility? And then out of that core, or that root of everything which you are as an infection preventionist, there are 2 major branches. One of them is your work within the environment of care, and the other one is your work within the clinical process area. So from WAC 246 through 2176, it states within the regulations of the state of Washington that your job is to identify and reduce the risk of acquiring and transmitting infections and incommunicable diseases between patients, employees, medical staff, visitors, volunteers, family members, those types of things. So that is the simple one-sentence statement of what your job is and what your core competency actually entails. As I mentioned, off of that foundation or off of that trunk of your functionality, there are these 2 pieces. First off, the environment of care, which includes your control, your input, and your supervision and coordination of facility cleanliness. Obviously, a large amount of what you have to do is a coordination with the housekeeping department, environmental services department, in order to make sure that the hospital is clean and presents a safe environment in which to deliver patient care. So the environment of care is a huge piece of your job. I sometimes see in facilities that I survey or I see from the results of survey from the Department of Health that some infection preventionists have worked so hard in getting themselves and their facility organized for the clinical process piece that they kind of have backed off from or have let slide a little bit their responsibilities within the environment of care. And we will talk about that a little bit more. Within the next section is biohazardous waste disposal. It is your function and your responsibility to coordinate with the engineering departments or with physical plant to make sure that biohazardous materials are collected routinely, they are stored routinely and safely within your facility, they are shipped to the appropriate locations for disposal, and that between you and physical plant or engineering, that the documentation is kept appropriately for disposal of all of that biohazardous waste. Third one is use of disinfectants and cleaners. It is the responsibility of the infection preventionist to know what all of the disinfectants and cleaners are that are in the facility, that you have a control over that process, and that all of those cleaners and disinfectants have been approved by you for use in the facility. One of the issues that you would obviously want to focus on would be if your safety committee or you are doing monthly or bi-monthly rounds of the facility, that you would always be on the lookout for any disinfectants or cleaners that you find that are not on your approved list of cleaners and disinfectants. And the fourth one in that section has to do with construction project supervision. It is very important that you have a strong voice and a strong role in construction projects that occur within the facility, because it is your responsibility to make sure that your patients, visitors, family members, guests, vendors, volunteers, physicians, staff in general are protected from any problems related to infection control that are associated with construction projects, primarily looking at things like sequestering of potentials for dust spread, that type of thing, mold, dust getting into the ventilation system, the HVAC system. The second half, the second major branch off of that foundation or trunk of your competency has to do with the clinical piece. And this is related to, again, the same WAC, but it's related to items specifically 5A through Q. First off is the standards of competency, meaning what are the things that are required by OSHA, or required by the Department of Health, required by CMS, and then to a best practice end required by the Joint Commission and by DNV related to your standards of competency. What are the things that are required of you in order to make you competent and to keep you competent? That's very important. It is the number one thing that surveyors look for when they get to your hospital and they meet you for the first time and talk to you. There is a breakout session, both for the Department of Health and either Joint Commission or DNV, related to infection control. They meet with you. They talk about your background. They talk about how you maintain your levels of competency. And so keep in mind that this is more rigorous than what you might think, but it is not so rigorous that it's impossible to do. But it is the number one thing that the Department of Health folks go looking for. Second one is once they have decided that there is a level of competency which is satisfied or satisfactory to the Department of Health, they then begin to look at staff education and competency. And believe it or not, it is the responsibility of the infection preventionist to make sure that all staff in the facility, not just clinical staff, not just clinical ancillary staff, not just food service people, but every employee in the facility has some requirement for education and training, mandatory safety training related to infection prevention, and that has to happen on an annual basis, and that the documentation of that annual staff education is available for you to present to the surveyors during their survey. Patient care practices in all areas are obviously something that is a high priority for you and is something which both the environment of care and the clinical surveyor are going to spend a lot of time assessing and looking for while they're touring the facility. One of the biggest issues, especially for small critical access hospitals, is the potential for contamination of clean patient care materials or items by dirty equipment or by dirty laundry or something like that. And so you see sometimes in smaller critical access hospitals that there will be one utility room in the nursing unit, as an example, and one side of that utility room will be the clean utility room, the other side will be the dirty utility room, and there's no permanent separation. There's no wall that separates the clean from the dirty work areas, and so that is the bottom line on what this one happens to come up with as a potential for a citation. Proper aseptic technique. There obviously surveyors are going to be looking for the ability of all staff to practice proper aseptic technique, proper attire when they go into a room which is in isolation or for a patient which is in isolation. They're going to be looking for occupational health compliance and your involvement in the employee health piece related to a variety of vaccinations, related to blood and body fluid exposures, those types of things. Because infection prevention has to have such a large role in that process, they will certainly quiz you about that, ask you questions about that, and then go out and look for the documentation of your participation in compliance with all of the occupational health issues. Pharmacy and therapeutics, obviously on an annual basis you have to prepare presentations, you have to prepare reports related to the kinds of bacteria that you have in your facility, what are their antibiotic sensitivities, the antibiogram issues that we're relating to, and making sure that the pharmacy is in participation with you and others in making sure that the facility is safe for patient care. And then last one is assessment and surveillance. A big piece of your work as an infection preventionist is to continually assess the facility for the potentials of infections, for poor staff conduct, in other words, poor staff competency in terms of caring for patients, and your surveillance of the facility with the potential for watching out for endemic situations like Clostridium difficile infections or something like that. Those are all of the pieces of the competency assessment that they're looking for when the Department of Health, Joint Commission, or DNV comes in to do survey for you. All right, within that realm then, let's take a look at some of the things which are commonly found within the survey issues itself. First one is failure to document core competency. Notice that I make reference to a failure to document the core competency as opposed to a failure of core competency itself. There isn't anyone that's going to say you're not competent as such. The problem with this is that the Department of Health, and we'll basically refer to the Department of Health as the surveying entity or the qualifying entity from now on, that within WAC 246, 321, 76, they are looking for those things which are the foundation or the core of your competency that you have to adhere to in order to continue to do your job. The first one is that you have to have a minimum of 2 years in a healthcare-related field, and that you have to have an adequate amount of training in the principles and practices of infection control. They will want to see that information, or they will want to have access to that information when they do the interview with you as the infection preventionist as part of their survey. The citations within this range of core competency are listed there as the next 4 items. One of the things that you can easily get cited for is your failure to meet those required background standards, or your failure to properly document your professional continuing education. This is the one that gets hospitals in more trouble than anything I have seen in the infection prevention arena. You may be participating in all kinds of things which provide continuing education for you, but if it is not properly documented, if you don't maintain those certificates, then you do put yourself on fairly thin ice. One of the first hospitals that got cited for this when I started working within the Washington Hospital Services area was a hospital whose infection preventionist was not participating in or a member of an APIC chapter, and therefore was not going to the APIC meetings and receiving professional continuing education credits. This particular infection preventionist was doing online types of infection prevention modules with a little post-test to them. I remember one of them being that they were doing a module on hand hygiene from Purell and taking the little 10-point quiz at the end of that and getting satisfactory grades or good grades on it. But the problem with that is doing online types of continuing education for the infection preventionist that is so rudimentary in nature that they really don't elevate you as the expert in infection prevention is something that's going to be a big problem for the surveyors, whether they're Department of Health, Joint Commission, whoever it is. The third one is that the issue of competency is related to the failure of the infection preventionist to discuss the risk assessment, general policies, and surveillance plan for infection prevention during the interview. As I mentioned to you, every survey they will take time to interview you, the infection preventionist, talk about your background, talk about your levels of competency, talk about the things that you're doing in the assessment and surveillance area. And if you fail to competently discuss your risk assessment, the comprehensive risk assessment for infection prevention that you have to do on an annual basis, a failure to discuss the general policies, your plans and processes for updating those things, running them past the medical staff, getting expert input into your policies and procedures, and certainly looking at them on an annual basis and revising them every 3 years. Those types of things can bring you a very quick citation. Certainly the surveillance plan, which is a core part of your job, will get a citation for you if you do not do a good job of explaining those to the surveyors. And I have seen this happen. I have seen this happen 4 times within the past 2 years where the infection preventionist would go into the meeting with the environment of care and the clinical surveyor for the Department of Health in this particular case, and to have trouble communicating their risk assessment, their general policies, the surveillance plan, their bacterial antibiogram type of things that got the surveyors to question whether or not this person as the infection preventionist was truly competent to do the job. And then the last one, and the very significant one, is that every piece of the infection prevention program has to be tied into the quality assurance and performance improvement process of the facility. In other words, your infection prevention program and all of your reports has to be going to the QI committee, the PI committee on a routine basis, that you have to be participating in that committee, you are reporting that information to that committee, and that information gets from you to the QI committee to the board at some point in time so that the board and administration understands what it is you're up to. Let's talk specifically now to the environment of care piece. This ties into anything and everything that is related to infection prevention that is not directly related to patient care. And as you can see, I gave you both the citation for CMS and for the WAC standards. If you remember, the ones for the clinical piece were the standard WAC, but then it was included in pieces 3A and B. This one is the environment of care piece. As I mentioned earlier, one of the easy ones to handle and one of the easy ones to take care of, but also one of the easy ones to fall into a difficult situation with, is to have control over the types of cleaners and disinfectants that are found in the facility. If you do not have a list or you do not know yourself what all is on your list of approved cleaners and disinfectants, it can bring you a very quick citation. When, as an example, if it's the wintertime and you are doing survey and you are escorting the environment of care surveyor or the clinical surveyor around and you go, I'm making up a scenario, so it may be a little bit far-fetched. If you go past the medical records department or you go in the medical records department, and all of a sudden here is a pressurized can of Lysol disinfectant spray, the first thing the surveyor is going to do when they see that can of Lysol disinfectant spray is turn to you and say, is this on your approved list of cleaners and disinfectants? If it is not, then it is likely to bring you a citation, because it wouldn't be just technical advice to say, no, it isn't, because you couldn't get past the technical advice to get that all removed fast enough and to modify your approved cleaners and disinfectant list to get it on there before they finish their survey. So you're not going to get technical advice for it. You will get a citation. Proper use and proper disposal and reuse of equipment. If you have equipment which is disposable, one-time use only, and for some reason or another you decide to reuse that, if the people in the OR request the ability to reuse certain types of equipment, it goes to you. You are the one in control of this process. You are the one that has to pass judgment on whether or not you can reuse that disposable piece of equipment, and therefore you have to have proper documentation in place that shows how you've assessed that process, what kind of research you did, and how you managed to approve that in such a way and modify or continually monitor that process to make sure that everything is working the way you're supposed to. Again, we talked about the cross-contamination thing. Be very careful about dirty and clean utility rooms. Be careful that if you have just one room that works for both the clean and the dirty utility piece on opposite sides of the room, make sure that the ventilation system on the clean utility room side is what's really blowing air into the room, and that the exhaust vents for the HVAC, the air movement, is in the dirty utility piece. So always remember, clean utility rooms have to have positive air pressure compared to the surroundings or compared to the hallway. And dirty utility rooms always have to have negative airflow compared to either the hallway or the clean utility room. They will look for that. That is always one of the things that the Environment of Care surveyor is looking for. Environmental care management, especially in the housekeeping area, means that you are doing continuing education for the housekeeping staff. You are observing those housekeeping staff mix disinfectant solutions, as an example, or properly cleaning floors in a patient room, or doing an appropriate and good post-isolation total clean of a patient room. Those are the kinds of things that are related to competencies of housekeeping staff and other staff that you have to be on top of. You have to be able to say, yes, I know that the housekeepers are doing an appropriate terminal cleaning of this room that did have a patient that was previously in isolation in it. So not only are you looking at the environmental management pieces related to housekeeping in patient care, as an example, or in the therapies, as an example, or specifically in food service area. You also have to deal with the hospital-wide daily and periodic cleaning as you do your rounds on a monthly basis, on a quarterly basis, whatever it is. You have to make sure that you are looking for dust in all kinds of places, dust behind the fire doors in the hallways, high dust on picture frames, dust in patient rooms, on the overbed tables, on the bed frames, those types of things, so that you know that the environment of care is appropriate for providing patient care in your facility and is not a risk of infection for anyone. This is an easy one to get away from you. This is one that takes a high level of coordination and cooperation between you and the housekeeping or environmental care services department in order to make sure that it works. Occupational health practices, make sure that things are going on in the pharmacy and laboratory that are protecting cleanliness, sterility, those types of things. That I'll give you one very quick example. In the laboratory, if you have a blood draw room, you have a chair out there in the blood draw area, that chair has to be wiped off. Horizontal surfaces have to be wiped off after every patient encounter. I have been in way too many facilities that said, well, yes, we wipe down our blood draw chair at least once every shift and maybe more depending upon how busy we are. Well, I will tell you right up front that if you as the infection preventionist are allowing the people in the laboratory to get away with that, you probably, I hate to say this, but you probably deserve a citation because it is an infection control hazard of the highest realm, and it needs to be taken care of in such a way that the laboratory, after every patient encounter, wipes down the horizontal surfaces of that blood draw chair. And then lastly, within that area of the environment care are the biohazardous waste management issues. Remember I talked about that. Where are the sharps containers going? Where are the blood and body fluid stuff going? Where are they being stored while on the facility? Where are they being transported to? How are they being disposed of? And are you getting all of the documentation that you need in order to prove that that biohazardous waste was disposed of properly? Okay, let's go look at a few more of them. We talked about construction supervision. The big concern here is that during construction, there is going to be dust generated, which will then spread throughout the facility, get into the HVAC system, and move all over the place. So if a construction process is going to happen, if some kind of remodeling is going to happen, that whole construction process has to go past you. It has to be approved by you. You have to be able to give input, and you have to be able to give direction in how that construction project or that remodeling is going to occur in such a way that you prevent that dust from spreading throughout the facility. I have been in, again, way too many facilities where construction and remodeling processes never even talk to the infection preventionist, or it's just a cursory, this is what we're doing, this is where we're going to be doing it, and this is when we're going to start, without asking for any input, any guidance, any direction from you. You do have that role, you do have that authority, and there is an expectation on the part of the Department of Health, on their part in terms of the CMS people and the Joint Commissioner DNV, that you are actively participating in those construction supervision processes. We talked about common citations for hospitals related to infection control, and that was dealing with food safety in the kitchens. You have to make sure, as the infection preventionist, in cooperation and collaboration with the manager of the food service area, that temperatures are being taken on a routine basis for refrigerators, freezers, hot tables, salad bars, all those types of things where there may be a risk of food contamination or food poisoning because of temperatures that were not either high enough or low enough. So, temperatures, make sure that they are documenting the temperatures every single day. Surveyors come in and find that there are 2 times or 3 times in the past month where the housekeeping staff, or not the housekeeping staff, but the dietary staff or the nursing staff or somebody like that did not document the temperature of the refrigerators, the freezers, those types of things. It raises their level of sensitivity to this stuff so high, and it just puts you at such great risk for getting a citation for it that is really hard to get out from underneath. So make sure that you are monitoring those things and keeping the housekeeping managers, the food service managers informed about what you're finding in those areas. Hand hygiene also. Surveyors from both the environment of care and the clinical side will go into the kitchen, and they will stand there and watch staff prepare food. They may be looking at an area where you have a small snack bar, as an example, and they're preparing hamburgers, or they're dispensing sandwiches, but they're also taking money in payment for that food, and looking for proper gloving, taking off the gloves when they take the money and make change, putting on clean gloves, washing hands appropriately, all those types of things. It is an easy one to have a citation for. And the problem with it is, if you get a citation, your facility gets a citation for food safety in the kitchen, it's not just the manager of food service that is responsible for developing a process for getting out from underneath that citation. It is also on you, the infection preventionist, to get out from underneath that citation. Proper cleaning of patient care equipment is always a big issue, because there's usually this gray area between, the patient care staff clean patient care equipment, sophisticated medical equipment, but what part do the staff clean? The housekeeping staff clean? Does the housekeeping staff clean the pole that the IV pump is on, or because the IV pump is on a pole, does the nursing staff clean both the pole and the pump? That type of thing. It happens in radiology, it happens in the therapies, it happens in nursing units, and it's an easy one for people to fall down on. And so you, as the infection preventionist, have to take the high road, the competency road, and make sure that there is a clear understanding between all parties about who cleans patient care equipment. Supply storage, again, the dirty utility, clean utility room, to make sure that you don't have any cross-contamination. And the last one in this section of the environment of care, believe it or not, is staff infection prevention education and competency assessment. You establish a standard for what is going to be considered a competent staff person when it comes to infection prevention issues. That means if they're watching a module, a computer-based learning module as an example, or you have a reading packet for them in infection prevention and they have to take a post-test or a quiz at the end of it, what is the acceptable standard for passing that quiz. Is it 80%? Is it 90%? You, the infection preventionist, have to set that standard. It is not something that your educator can set. It is not something that your HR department can set. It is something that you have to set. All right, let's switch to the clinical side of this thing and take a look at where there are potential citations. The clinical process is the validation of all of the compliance with everything that's going on in the facility that is related directly to patient care. So it has to do with your infection prevention standards. It has to do with your routine surveillance process. It has to do with your ability to see and to understand the global picture when you see an outbreak occurring, and what kind of interventions are you going to take on when you see something like that happening, or the potential for something like that happening. First off, the policies and procedures, and maybe I haven't spent enough time yet talking about infection control and surveillance plan policies and procedures. As I mentioned early on, infection control, infection prevention policies and procedures have to be reviewed annually, and every 3 years there has to be the notation for revision of those policies if there were revisions that had to be made. I will tell you there are no absolutes, so you can't say that every infection control policy has to be revised every 3 years, but surveyors will also tell you that it's highly unlikely that a policy in infection control didn't need to be revised once every 3 years. So it's up to you. You're the competent person. You are the specialist. You are the expert in this area, and so it's up to you to determine whether they had to be revised in 3 years, but don't risk leaving large portions of your infection control policies unrevised for many years. The other thing is they do have to be reviewed every single year, and there should be documentation on the policy that says within the past 12 months this policy was reviewed by infection prevention, by the medical staff, as an example, to make sure that it still was current and appropriate for your facility. Next one talks about your supervision of all patient care practices in every single area of the facility, whether it's in the therapies, the OR, the nursing units, the lab, the pharmacy, food service, wherever it is. You do have control over infection control processes, obeying of the policies and procedures that you have written that have been approved by your medical staff for everything related to patient care and infection prevention. So be aware of it. You can go through the whole process. You can have surveyors look through all patient care. You can have them follow the whole tracer mechanism, but there are a lot of places in there that are going to catch you if you're not very closely related to all of the things going on in patient care for practice. We talked about some of the other related areas where you are responsible for making sure that patient care practices are being obeyed. It includes radiology, procedural suites. Make sure that the point of care testing that's being done is in compliance with all of your policies and procedures. Make sure that you are properly surveying your surveillance plan. You are investigating and reporting communicable diseases that are required under the WACs. Make sure that you do conduct every single year, and this is an annual thing. Notice it doesn't say yearly, it says annually, which means every 12 months you have to conduct a comprehensive risk assessment for infectious diseases. Do not let that thing go 13 months. If you let it go 13 months, you will get cited for it. Okay? So make sure that you have your comprehensive risk assessment done. You are doing a good job of surveillance in the facility for communicable diseases. You're looking for potential outbreaks. Make sure that antisepsis is being practiced appropriately in all areas of patient care, and that there is competent practice of isolation techniques. And make sure that you understand what is involved in the isolation policies, and that all staff are practicing proper types of isolation techniques at all times. You know, I have to tell you, one of the things that I see that just sets me off faster than anything else is if you have isolation posted on a patient room, and where do they post the isolation signage? On the door to the room. And if the door is open, the staff member or the family member who wants to read what the isolation policy says or the type of isolation that has been posted, they have to walk in the room. They have to step inside the room in order to read what's posted on the door. You cannot post isolation policies or isolation types on the doors of patient rooms. They have to be posted on the door frames. Otherwise, you get a citation for it. Tracer methodology is used by everybody. And so you need to be comfortable with the tracer methodology that is being used and be able to answer questions, because this is the part where even though they're examining patient care practice, they are looking at infection control and the whole process. And so tracer methodology for infection prevention, which is tied in with the tracer methodology for all of patient care, is tied to, first off, identifying an individual patient with an infectious disease. How do they know which infectious disease to talk about? They will ask you, what are the types of things that you're seeing? What is the last infectious disease patient that you had that had to be admitted from the ED? Once they have identified that patient and have been given the chart for it, then the review process, their tracer methodology, is going to be making sure that you were involved in the process, you were notified, you gave input in how to take care of this patient, that lab testing and the confirmation process got to you so that you could see it, that you have supervised and that staff have been properly oriented in taking care of this patient with the infectious disease, that you are comfortable with the staff's competency training so that you know they can do a good job, not necessarily that they are, but that they can do a good job because they have had the training to do that. And that your current and past surveillance activity has given you some background and some understanding of this infectious disease so that you are not flying in the dark, shall we say, in terms of how to respond to this particular type of disease. The tracer methodology is either very straightforward or it's greatly convoluted depending upon how well the staff have followed your policies and procedures, plus the patient care policies and procedures in taking care of patients with these specific infectious diseases. I wish I could tell you that this was not one that is bothersome in terms of surveillance, but it is one that is very bothersome, and it takes a lot of time, and it is not something that you're likely to get a kind of a technical advice on. You will indeed get a citation for something in this thing for tracer methodology. Another part of this whole tracer methodology is then that you need to know and have a good understanding of all of your infection control data, of how you're reporting it, who you're reporting it to. If it's an infectious disease that needs to be reported to the CDC, did you do that on a time-appropriate basis? Are you in control of how things are happening in terms of isolation? Are housekeepers being properly trained and educated on how to handle this particular type of infectious disease patient? Are all staff practicing proper hand hygiene? I will tell you, and you know it, I'm sure, that the surveyors spend what seems like an inordinate amount of time at the nursing station just standing there watching staff go in and out of patient rooms, and are they practicing proper hand hygiene? If they are not, and in many cases they will not be, you will get a citation for it. So everything from isolation practice to hand hygiene to vaccinations, how food gets into the patient room, how food is being stored in the kitchen or in the food service area within the nursing unit, are supplies being disposed of properly, are dirty linen hampers being transported from the patient room to the dirty utility room covered so that they're not an infection control hazard for anyone else in the nursing unit, those types of issues. In other words, when you have an infectious disease, you are right there on the top of this whole thing because the surveyors are going to expect that that's happening and that you can respond to all of their questions. All right? Lastly, just the common citations. What are the things that I see most often in the area of infection control, both from the environment of care side and from the clinical side? Number one thing for citation for the environment of care side of infection prevention is dust. Dust on windowsills, high dust in patient rooms, on the top of picture frames, on the top of television sets, that type of stuff. Second one is cross-contamination. Proper airflow is something that the environment of care surveyor is going to drive you crazy with. They are going to constantly looking for proper airflow in clean utility rooms, positive airflow, dirty utility rooms, negative airflow, housekeeping closets, negative airflow, ORs, the most positive airflow in the facility, followed by the substerile areas, followed by the rest of the OR, followed by the hallways, that type of stuff. The third thing that there is the most common citation that I've ever seen has to do with the competency of the infection preventionist. Make sure that you have all of the documentation in place and that both you and HR have that documentation so that HR can get the documentation into your personnel file so that when it comes time to have the surveyors look at those personnel files, it's all right there in front of them. There's no question about whether or not you're competent based on the documentation that you have. The fourth thing, which is the most common citation that I have seen, is a lack of documentation of staff training. Not a lack of training necessarily, but a lack of proper documentation. And it usually falls on the fact that it's not everyone that's got the documentation. As I mentioned at the very beginning of this, every employee in the facility has to be trained on infection prevention, every single one of them, whether it's just general bloodborne pathogens or it's the entire process of proper hand hygiene and everything to deal with the clinical side of infection prevention. Every staff member, every single year, has to do some kind of training related to infection prevention and control, and it has to be properly documented. The fifth area that I see, and one that kind of blindsides people, I have to tell you, in many situations, has to do with food service issues. That piece about missing 2 or 3 times a month in terms of recording the temperatures of refrigerators or freezers or salad bars, that type of stuff, will get you a citation before you can do anything about it, and there's no way to get out from underneath it other than to develop an entire program for the next year and a half until your next survey. Hand washing. In food service areas, there is a designated hand washing sink. The surveyors do not want to see staff washing their hands at a sink that is used for preparation of vegetables or rinsing off vegetables or something like that. There is a designated hand washing sink, and the staff better be using it. And then proper food storage. Are boxes or baskets of food setting on the floor in a storage area for your dry storage? Are there spills that are occurring that are not getting cleaned up on the floors? Are there foods stored in refrigerators that are in individual servings, jellos, puddings, that type of stuff that do not have a date in which they were placed in that storage unit, that refrigerator or that freezer? Any of those types of things will draw citations quickly. And the last one in the environment of care piece is the employee health issues. That is directly related to your assessment of what your TB standards are going to be, who are you going to be doing TB skin testing on, if anybody, who are you doing the routine vaccinations on, are you assessing people for their antibodies to measles, mumps, rubella, that type of stuff. In other words, they want to see that the infection preventionist has large volumes of input into employee health issues. And on the clinical side, the number one thing that I see as citation is failure to comply with posted isolation signage. That means not only do they not glove and gown like they're supposed to, or they do not do hand hygiene as they walk into the room and as they come back out of the room. Things like, did you put the isolation signage on the door? And the door is propped open so the staff member has to walk in and read the sign there before they can even figure out what they're supposed to do. Failure to post that proper signage for isolation. Then the hand hygiene piece. Like I said, it seems like surveyors spend an inordinate amount of time standing at the nursing station or standing in a nursing unit watching staff go in and out of patient rooms to see if they're practicing proper hand hygiene. Failure to regularly review and revise your infection prevention policies. You could get through all of these other things. You could get through hand hygiene. You could get through all your tracer methodology. You could get through doing your surveillance and all that. But if your policies and procedures are out of date, you are sunk. And the way they see that is if your policies and procedures are out of date, it brings into question your competency. So if your policies and procedures are not up to date and you haven't done anything about it, you really aren't considered to be a competent infection preventionist. Okay? And the last one is the current risk assessment. You need to be doing your annual comprehensive risk assessment for infectious diseases in your facility. It needs to be written up. It needs to be shared with your QA and PI committee, and it needs to get to administration and your board. Antisepsis during surgical procedures, you need to be monitoring that on a routine basis, maybe quarterly, semi-annually. Make sure that scope cleaning is properly documented so that there can be tracers, tracking of which scopes were used on which patients for which procedures. Sharps and biohazard material disposal. Yeah, obviously the simplest thing in the world is make sure that none of the sharps containers are overfilled. And yet, you'd be surprised how many times when I'm doing survey, I find sharps containers that are overfilled and they just haven't caught up with it yet, meaning the MA or the unit secretary or somebody like that hasn't changed out that sharps container. Gaps in the tracer methodology, we talked about that one. Failure to know the identification of the facility's most common hospital-associated organisms. As part of your bioanagram type of thing, the surveyors will ask you about what are the organisms that are most commonly found in your facility, what are their antibiotic sensitivities and resistance so that you can then talk to them about that and show them your report on an annual basis so that they can know that you are up to date on which organisms are found in your facility. Or for that matter, if you have enough of a program in place that you may be able to even talk to them about what are the common organisms found in the community if there is anything unusual. And then the last one is the failure to do the annual TB risk assessment. Okay, that's my presentation. I am now going to open it up for your questions.
Thank you, Randy. This is Jamie. That was a great presentation. I think you did a fantastic job. So we do have Sue Rhodes has sent in a chat. So I'm going to read this to the group. We heard once that surveyors were citing for computer keyboards that didn't have covers or skins on them. Is that the case? Or is it that surveyors want to see that you have a solid process in place for cleaning keyboards?
Well, the answer to that one, Sue, is that the surveyors do want to see that you have some kind of a process in place for cleaning keyboards and making sure that the keyboards are not a source of infectious disease. Whether or not it means that you put skins on the keyboard is entirely up to you. But what usually happens is that once the surveyors start asking about the process for making sure that keyboards do not become a fomite for transmission of infectious agents, that they begin to see that there's not an awful lot of there's not an awful lot of thought that's been put into that one, or that there is a concern for maybe a gap in the infection control process for it, and that's when they start asking about, well, have you thought about computer keyboards, computer keyboard covers, a skin for them, or what are you doing? Did you buy dishwasher-safe keyboards, and how often are they being cleaned, and how often are they being run through the dishwasher, that type of thing. So the answer to the question, Sue, is they are looking for a process that you have in place for making sure that keyboards are not a fomite for the transmission of infectious agents, and then they will dig deeper if they don't get a good response.
I know when Randy spoke on this topic in Spokane, we had a ton of questions. It looks like Yvonne has a question. Yvonne's from, I believe she's from Sunnyside. Can you speak more to the isolation signage posted on room doors?
Well, certainly. Well, Yvonne, the deal with isolation signage posted on room doors, well, let's talk about the isolation signage. As you know, and I'm sure your facility is in compliance with, is all signage in the facility related to patient care. In other words, anything that you find in the patient care units has to be laminated first off so that it has a covering on it that can be wiped down with a disinfectant so that they are in themselves not a fomite for the spread of disease. The issue with isolation signage posted on the door itself and not on the door frame has been around for a long time. It is one where you could probably come up with some gray areas in terms of discussion of why signage should not be posted or should be posted on room doors. And so the standard for all the hospitals in the state is that you cannot post isolation signage on the room door itself, because even if you say the door to that room will be closed at all times, at some point in time you have to open the door to go into the room. And if you don't close the door behind you immediately when you go into the room, somebody else may come to the door, bring you something, want to come into the room, and they're going to have to step into the door, step through the doorway in order to read what the isolation policy or the isolation signage says. So the general rule or the applicable standard for this is that you do not post the signage on the door, you post the signage on the door frame. From Carla Boyd that says, what type of annual training is acceptable? Must there be classroom or teacher-led classes, or is it adequate to utilize canned sessions? Well, that's a good one. That's an excellent question. The type of annual training that is acceptable, actually there has to be both a facility-wide and a department-specific type of training for infectious diseases, unless you are in something like medical records maybe, or maybe administration or in the medical staff office. But for most people, there's going to have to be two components to the training of staff. One of them is going to have to be a generalized module, which you could do that could be a CAN session, a computer-based learning module. But there also has to be then some kind of training which is job or job category specific that is also documented. It does not have to be a classroom or teacher-led class. Does not have to be that, as long as all staff that do these training modules are given the information on who is the expert, in other words, the infection preventionist, in your facility. How do you get a hold of that person if you have a question, and how will that person respond to you? The big deal on this whole thing, Carla, is that there has to be access to an expert who can answer questions for staff when they watch one of these canned modules, or there is a discussion within their own department about infection control or infection prevention related issues. And so you don't have to have a classroom with a teacher in it, but you have to make sure, absolutely have to make sure, that everybody has access to the expert by giving them the name, giving them the email address, giving them the extension number, whatever it may be, so that they can ask questions and get clarification because of something that they were trained on related to infection prevention. Okay?
Thank you, Randy. We have a question in from Sandy Edwards. She wants to know, with regard to the signs on the doors, but what about PPE bags that hang over the door?
Well, I have been in places, I mean, this has been quite a few years ago, where they actually had a, how am I going to describe it? It was a hooked type of shelving unit, I'll call it, I guess, that was hooked over the door of a patient's room where the patient was in isolation, and they put the personal protective equipment, gloves, gowns, goggles, masks, whatever it may be, on this shelving type of unit that hung over the door. And to be quite frank about it, I have not seen that, Sandy, in a long time. And my gut instinct to this one, my bottom line on this one in terms of infection prevention is that that's really not an acceptable process either, that there should not be these shelving units that hang over the door in which you put the PPE so that the staff can retrieve them. Because, again, you have to walk into the room without the personal protective equipment on in order to grab it first, and then step back out in the hallway in order to put it on before you really go into the room to do some kind of work or care for the patient. So at least in principle, no, the hanging of PPE bags over the door is not an acceptable process.
Thank you for that question, Sandy. It looks like Sue has another question for you. Continuing education for the IPs. How to handle resistance by the organization for funding ongoing education for the IP. I'm certified. I hope, Sue, let me know if it's okay to read this out. She says, I am certified and experienced, but that shouldn't be the end of the story, just as you have pointed out. Even fairly accountable professionals need some degree of employer financial support. A citation would probably help, but that would be seen as a shortcoming of the infection preventionist. Randy, what advice do you have for those of us trying to get organizational support for our continuing development?
Well, that's an excellent question, Sue, and I think you and I both know that there has to be a requirement on behalf of the facility to fund appropriate professional education for the infection preventionist. I will relate to you a story, and maybe then you can carry the story forward, or others can carry the story forward for their own facility in terms of getting that type of funding. When I first started my job with the Rural Healthcare Quality Network, one of the first hospitals that I got a call from related to survey was a hospital who was not sending their infection preventionists to any kind of professional education. In other words, their infection preventionist was not a member of APIC. Their infection preventionist was not going to APIC meetings and getting continuing education. Their infection preventionist had never been on the CDC website to do any of their continuing education modules. And what happened with that hospital is that the surveyor threatened them with closure because of the incompetency of the infection preventionist. And believe it or not, they are totally within their rights in the Department of Health to start that process of bringing the hospital before an administrative law judge within the Department of Health to begin the process, to begin that step-by-step process of closing down the facility, mainly because infection prevention is such a core issue to the safety of patients as they're being cared for in the facility that if you can't create an infection prevention process, a program which is going to guarantee that safety of the patients during their care, then in the eyes of the Department of Health, in the eyes of the Centers for Medicare and Medicaid Services, and certainly in the eyes of both the Joint Commission and DNV, since they are best practice people, they have all the reason in the world to close you down. And so it is a lot less expensive and it is a lot more positive in its nature if that hospital finally does come up with the funding to allow the infection preventionist to become a member of an APIC chapter and to take that time once a month, once every other month to attend the APIC meetings and get the continuing education that is required. It is nearsighted and very risky to not provide the opportunities for your infection preventionist to become as competent as possible because you risk actually getting the facility closed down. That's my take on it. It is supported by state law and it is supported by the Department of Health because I've seen them on 3 occasions now try to do that in the past 8 years. That's scary as all get out to think that you're going to that they have the strength and they have the ability and they actually have the intention to participate in a close down, calling the hospital before an administrative law judge just to take care of that issue.
Thank you, Randy. That was very helpful because I know, especially in the critical access hospitals, one of the things that we hear quite often is that maybe not enough hours are provided for the infection prevention work. And we know that in both the CMS and the state guidelines, there is that provision of adequate resources that the hospital must provide for infection prevention. And so I think you've already sort of explained how the surveyors use that particular rule to help support infection preventionists. We do have a question that came in from Lori Benson, and she says, what is your take on allowing employees to work prior to getting their MMR titers back?
The answer to that one is no. They should not be working until you get their MMR titers back, period. The other one that can be added to that, Lori, as a caveat is that you dare not take the word or the documentation of someone else's MMR titers or TB skin testing as acceptable in terms of your allowing employees to work prior to getting back an MMR or a TB skin test from you. So no, they should not be allowed to work until you actually have the MMR titers back yourself. I will share with you a quick story about that one. One of the facilities that I worked in used nursing students, and those nursing students, the facility was provided with documentation from the nursing school that said that all of the TB skin tests for all of these nursing students were negative. And so after the semester was over in the spring and this particular nursing student graduated, the facility hired her as a nurse and put her to work right away, relying on the TB skin test titer type of thing, this TB skin test that the school had provided them. She worked for almost 9.5 weeks before she was diagnosed with an active case of tuberculosis. And all of the patients that she cared for during those 9.5 weeks, all of the staff that she came into contact with for those 9.5 weeks, all of the family members that she came in contact with for those 9.5 weeks, every single one of them had to go back into the employee health department of that hospital and have an initial TB skin test done with a follow-up 6 months later. The cost alone was huge. The problem, again, was that the hospital employee health relied on a school's documentation of a negative TB skin test when indeed they should have done their own at the very beginning. They would have caught it and it wouldn't have been a problem. So no, they should not work without their TB skin test. They should not work without you having your MMR titers.
Thank you, Randy. So Yvonne has a follow-up question. She says, I understood they could decline MMR immunization as well as other immunizations other than TB screening. What exactly is required as you understand the rule around immunizations and screenings upon hire?
The ability to decline the MMR immunization and any other immunizations which you may be requiring is a huge legal issue for hospitals. It is a legal issue that is related to things like religious issues, and so it is a very difficult one to walk through in order to get protection for your patients and everyone else in the facility. Boy, I wish, Yvonne, that I could answer this one easily. This one is not an easy one. It is sometimes a question that the surveyors will also ask if they're convinced that everything else you're doing is great. They may dig down this far, but it's not one that you can just say is a black and white issue. What is required, as far as I know, well, for a person who declines to do MMR immunization and get the hepatitis A, hepatitis B types of things, sets themselves up for screenings on a routine basis. It sets them up for a limitation in which areas within the hospital they actually can work, limits them in terms of the types of procedures that they may be involved with. And so there are issues or questions that come up that with their ability or their capacity to work in your facility, if you're going to require those things, and you can't guarantee them that they will be limited to working in just a selected area for a selected number of hours. And thank you very much, Yvonne. I understand the challenge with it for everybody. It is definitely not easy, and it is as much a legal issue as it is a professional issue as anything.
So, Randy, this is Jamie. If an organization who's still struggling with this declination, if they have documentation that every employee has either received the vaccine, has a positive titer, or a declination on file, because at this point that's all that facility can do, would that be acceptable to the surveyors at this point?
Well, yes, in terms of you're doing everything you possibly can to protect the facility, protect your patients. You've done everything that's required by the law, and so they won't give you a citation based on what you have done. You will not receive a citation, but they probably will give you technical advice on, here's a person you might want to contact about this within the Department of Health, or this is something that you might want to look into, or this is a new paper that's come out from the American Medical Association on this issue, but you will not get a citation.
Great, thank you for that. Yvonne's follow-up question says, it sounds like we would need to develop policies around the ability and capacity to work for those employees that have declinations. Could this be a discrimination issue with those employees?
I don't believe it would be declared discrimination because they are discriminating against themselves. They are discriminating on what they are willing to do based on their refusal to do the MMR titer and immunizations. They are limiting their ability to work. They are limiting their ability to work based on their refusal to do hepatitis A, hepatitis B, that type of stuff. So it would be hard for them to prove discrimination on behalf of the hospital, when indeed they're the ones that are saying, I don't want to do this, I'm not going to do that, I refuse to do this.
Thank you, Yvonne, for all of those questions. All right, Randy, do you have any parting comments for us? Words of encouragement, perhaps?
Words of encouragement.
Warning.
or warning. Well, the words of encouragement would be, it is very, very seldom ever an issue of having incompetent infection preventionists. The issue is always that there is a lack of documentation, appropriate documentation of the competency of the infection preventionist. So work on the documentation piece of it. You don't have to worry about, the Department of Health does not come in thinking that an infection preventionist is an incompetent person. They just come in and expect to see the documentation of it in place. The other one that is always the great concern is, again, policies and procedures. Make sure that you are documenting that you have reviewed your policies and procedures every single year and that there is a process in place for revision of those things so that on the average, every 3 years, you are doing a revision. Those are my words.
That's great. Thank you. If you want to click on the next slide with your contact information, I think folks would really appreciate being able to maybe reach out to you if they have some issues. Thank you.
There you are.
Okay, so Yvonne says, how about utilization of fans to circulate air in a patient room related to infection control?
The general line on this one, Yvonne, is that any fan that you use in a patient room has to be cleaned after every patient use, and so every time you take a fan into the room, it has to have been cleaned by the housekeeping or the environmental services department before you can put it in there. You can't take a dirty fan, put it in a patient room, use it to cool the room while they're there, then just take it out and move it to another room. You have to take it apart, and you have to clean the blades and everything between patients.
Thank you so much, Randy. We really appreciate it. Yvonne follows up to say she's very glad that they'll be able to use the fans as long as they get them cleaned thoroughly. Also, Sandy Edwards has asked whether or not this recording is available. It will be. It usually takes us about a week to get the recording converted from the WebEx environment into something that most of you can view. So give us about a week. We will send out a link to where you can find that recording. Also, following this presentation, we'll send out Randy's handout with the resources and references that he talked about today. And, of course, if you have any further questions, we also have a Survey Monkey. You're welcome to provide us with information about additional information that you need. And I think Randy is probably open to suggestions as well. You're welcome to contact him or us about survey needs and other things. Randy, thank you. We really appreciate your time today, and we appreciate all of you staying on the line for this rather long webinar, but I think it was very valuable. You guys have a great week, and we'll see you July 22nd as we talk about mandatory reporting of HAIs in critical access hospitals. Thanks again.